Namaskar, Sat Shri Akal, Adab. Good morning, good afternoon, good evening to all of you. Thank you for joining our live session. My name is RJ Kunjan और हमें आपके host and host for today's FB live session. These are unprecedented, unpredictable times. Tell me something. Did you ever think it's possible to have the most experienced, highly qualified, compassionate doctors at the click of a button? Well, eGlobal is the answer with affordable, secure web application, online healthcare, remote consultation, membership options, personalized health passport, and many more amazing features. In today's Facebook Live session, we will be exploring and providing more information about sleep wellness. We have the expert in-house with us, Dr. Anup Katyal. He is ICU critical care expert, board certified in 5 specialties: internal medicine, sleep medicine, critical care medicine, neurocritical care medicine, with over 25 years of experience. It's really nice to meet you, Dr. Anup Katyal. Thank you for sparing time for us. I know you're super duper busy. Welcome to FB Live.
Thanks for having me.
So how are you doing this evening?
I'm doing good.
Thank you. So tell me a little bit about how are you associated with eGlobalDoctors?
So since its inception, I've been very proud of my association with eGlobalDoctors. When the pandemic hit India, the Delta variant, eGlobal came up with this platform for us to provide telehealth services to people all over the country. And so credit goes to the administrators for coming up with this kind of platform, which is very user-friendly. And obviously, the number of doctors and the volunteers at eGlobal who made our life very easy as we tried to help people back home in India.
That's wonderful. So thank you. कहते हैं भगवान और डॉक्टर में अंतर नहीं होता. You guys are gods for us. So thank you so much. So before I move to the next question and आज का topic, I want to ask you, tell us a little bit more about the new virus, that Omni virus that we are hearing. What's your take on it? What are the different precautions that we should be taking besides what we already have been doing?
So the world obviously has now been hit with this Omicron virus, first reported from South Africa. And it comes as no surprise that it is now being detected all over the world. So the problem with this variant is that, it has about 30 mutations on the spike protein, which is a huge number of mutations. And the concern is that, if you've been infected before, the natural immunity may not protect you against this variant. There is some concern also that we have some of the medicines like monoclonal antibodies that we use that may also not be effective, and some concern that the vaccines that were effective against the alpha, beta, gamma, delta, lambda variant may not be effective against the new South African Omicron variant. It is too early to say. As I mentioned, in the next week to 2 weeks, one would have better idea as to how much protection the mRNA vaccines here or the Johnson & Johnson vaccine, the two main categories of vaccines available here, at least in USA, as to how much protection they would afford. The thought is that if you've received the 2 doses for the mRNA vaccine and received the booster, then you should have what is described as a cushion effect, that it should afford some protection, but everyone is in agreement it would not be as much protection as we got for the Delta variant and the other variants. But it's too early to say.
It's too early to say. Okay, we'll keep an eye. And obviously you are here as an expert to help us. So thank you so much. With that, I'm going to come back to our topic. Our topic today is sleep wellness. So another question that I want to ask, when I was describing your specialties, I don't know what else you're hiding up your sleeves, but tell me, what is neurocritical care and what disorders in particular fall under this specialty?
So neurocritical care is a specialized branch of critical care. So the patients that we see sort of in the neuro ICU would fall in the category of people who have a stroke or a brain attack or a bleed in the brain, or when we have patients with traumatic brain injury and they have devastating injury, they come to the neuro ICU. We also deal with patients with a different kind of bleed called subarachnoid bleed. We see patients with brain tumors. We see patients with infection in the brain, whether it is meningitis or encephalitis. In addition, we also see patients with neuromuscular problems like myasthenia gravis, GB syndrome, etc. And it also entails people who have injuries to the spinal cord, like traumatic spinal cord injury or cord compression. So all those come under neuro emergencies that we see. In addition to obviously people who present with seizures or epilepsy, where we have to sometimes put them on several medications to get control and put them on the breathing machine, so to speak. So it encompasses a huge amount, of these different entities that I spoke about in neuro ICU.
Thank you for that wonderful information, Dr. Anoop. I'm going to move to the next question. So, I have heard different numbers from different people. Some people say 6 hours is a good amount of sleep. Some say 8. I want to know from you as an expert, how many hours of sleep should a person really get?
So that's somewhat of a tricky question. What I would say is how much sleep an individual needs depends on one's own needs. In general, we say when you're born, a newborn needs 14 to 17 hours of sleep. As you go into the adult phase of your life, we say that, about 7 to 9 hours of sleep is needed. And once you're above 50 to 65, then we say 7 to 8 hours of sleep at night is needed. If you think of it, you spend about a third of your life sleeping. So what happens in sleep counts for a lot. But to answer your question, one way of looking at how much sleep an individual needs is you try and figure out how much sleep you get on a weekday and then how much sleep you get on a weekend. So suppose in your busy schedule, you're getting, say, 6 hours of sleep Monday through Friday, but on Saturday, Sunday, when you don't have to go to the office, don't have to work, you're sleeping 9 or 10 hours. That means your sleep requirement is somewhere in between, so about 8 hours. That's one way of figuring out how much sleep an individual needs. So whatever sleep one gets, it is not just a quantity of sleep, and like we may discuss more, it's also the quality of sleep that is of paramount importance.
That's actually wonderful to know. So take the average of all 7 days, and that's the amount of sleep I should be getting if I'm talking for myself.
Sure.
Okay, wonderful. So how do I know? Like if somebody says, hey, Kunjan, it's time to see a sleep expert. Why see a sleep specialist? Like, how would I know that I need to see a specialist?
So people think when they see a sleep specialist, all he or she is going to do is talk about, insomnia, but the sleep field is actually very broad. And not only does it include insomnia, but people who snore and have sleep apnea, which we call as obstructive sleep apnea. There's another kind called central sleep apnea. In addition, you may hear people who say that they do strange things in the middle of the night that we call as parasomnias. And sometimes we have more common, obviously, in men than in women, people act out their dreams. It's a very serious condition called REM behavior disorder. It's also a kind of parasomnia. In addition, we see patients who have excessive daytime sleepiness. It's called narcolepsy. We also see people with, circadian rhythm disorders, jet lag, shift work sleep disorders. In addition, we also see people who have what is commonly described as restless leg syndrome, that they have an uncomfortable feeling that prevents them from falling asleep, or they cannot sit still for extended periods of time. So sleep not only includes insomnia, but these whole categories that I mentioned. So if you look at a sleep practice here, with increasing number of patients who are, getting obese with, dietary restrictions not being followed and so forth, we are seeing more and more patients with obstructive sleep apnea. And to a common person, it may sound as, oh, he's snoring or she's snoring, that's of nuisance value, but it has significant other health ramifications.
Wow. So that's a pretty wide spectrum. I did not realize that at all. So you mentioned a term insomnia. So what is insomnia, if you can shed some light, and how would somebody know that they have insomnia?
So insomnia per se is either difficulty falling asleep or staying asleep. And we divided it into two broad categories. One is what we call as short-term insomnia. That happens, a student gets a poor grade in a particular subject for several days, cannot, fall asleep or stay asleep, or there is a death of a near or dear one. That's short-term insomnia. When we say chronic insomnia, it is basically defined as when you have symptoms of either having difficulty falling asleep or staying asleep for 3 months, and you have the symptoms for at least 3 nights a week. And moreover, your insomnia should be such that it should have ramifications during the daytime. It affects your functioning during the daytime. So that is what we call as chronic insomnia, that when it lasts more than 3 months, and at least you have 3 nights a week when you have this problem.
So that's a trigger. If I'm not able to fall asleep or stay asleep for 3 nights in a row, then chances are that I may have some kind of insomnia.
Exactly.
Okay. Well, thank you for boiling it down to someone who does not understand too much medical terms. So that's really helpful. So does that mean that everyone I know and maybe me have a sleep problem?
So if you look at surveys that are done, there's something called National Sleep Foundation that carries out surveys every year. Now everyone is dealing with the pandemic, so the stress of it obviously has affected, I would say, every adult's sleep. With regards to virtual learning, staying at home, the unknown, and now, as you mentioned early on, the new variant. So the 2020 survey, at least in the United States, said 44% of the adult population, at least 3 days a week felt tired and sleepy, suggesting that they were not getting, either the right quantity of sleep, or if they were getting the right quantity of sleep, the quality of sleep was poor, that it had ramifications the subsequent days.
Interesting. 44%. That's a big number, exactly. Right there. Exactly. So tell me something. When I have heard, and I don't know if it's a myth or if it's true, but people say if you can't sleep, don't take sleep medicines, because once you start taking them, you get addicted. So what's the myth about the sleep medicine? Is it only for the people who are suffering from insomnia, or people who can't sleep? So shed some light on that.
So I've been practicing sleep for over now 2 decades, and you'll be surprised that it's only a handful of people that I prescribe a sleeping aid. So it all starts with a very good history and looking at sleep hygiene. So those are simple things that you can tease out, that, if someone is having too much of caffeine close to bedtime, having heavy meals close to bedtime, exercising close to bedtime, those are things that can affect your sleep, or, taking certain medications that can be promoting, the wakefulness at night. So you have to get a detailed history from a patient. Is the patient anxious? Is the patient depressed? Is there some pain issues? So try to tease that out. What is causing this problem? I briefly mentioned that restless leg syndrome. Some people say they try to go to bed, but they have this uncomfortable feeling in their lower extremities. And then, that they cannot lie still, they have to get up and walk, and that prevents them from falling asleep. So if you know what the trigger is, try to address that. So that becomes the most important thing. As far as management is concerned, there are two approaches to it. One is what we call as cognitive behavioral therapy, that is not relying on medications. And the second part is, relying on medications. So when we talk of sort of cognitive behavioral therapy, simple things first, as I mentioned about, sleep hygiene. If you're drinking too much of tea, coffee close to bedtime, avoid that, simple stuff like that. And then we talk about certain other things that, whether some relaxation techniques, if you have restless legs, treat that. If there's anxiety, address that. And then we talk about something called, stimulus control and sleep restriction, which are some behavioral interventions that we talk about. As far as medications are concerned, you'll be surprised there are several categories, starting from benzodiazepines or benzodiazepine agonists, like, patients must have heard Ambien, Lunesta, Sonata here. Those are some medications. Melatonin agonists. Then you have medications like tricyclic antidepressants like doxepin. And more recently, we have something called a wake promoting, protein that is produced by your brain called orexin. So people now have come up with medications that oppose the effect of orexin, so help you sleep. So there is a whole bunch, in addition to over-the-counter antihistamines. So you have a slew of medications available, but unfortunately, when we talk of cognitive behavioral therapy, there has to be a buy-in, from the patient. But people are always looking for quick fixes, right? Give me a medicine. And I will also point out that sometimes when people have sleep maintenance insomnia, it's the sleep apnea that is causing the insomnia. So I also tell people that, assume you are running a fever and you come to me with a pneumonia, and I say, oh, you're running a fever, take a Tylenol. The Tylenol will help you with your fever, but will not fix your pneumonia. Similarly, if you have insomnia and the cause is sleep apnea, and I tell you, take a sleep aid, it may help you, but it's not fixing the underlying problem. So I try to go into what the cause may be and address that cause.
That's actually wonderful to know and very enlightening. I had no clue. So thank you so much. Like I mentioned when I was talking to you, sleep is my long lost friend. So I would really like to get it back. So you did touch upon something which I think we all need, which is caffeine. I know that that's my daily poison. I do need my caffeine to function. So if somebody sleeps at 10 p.m., you mentioned that don't have caffeine near your sleep time. So do you have like a general guideline for people like me who function on caffeine?
So we tell people, caffeine in moderation is fine. So it is the most readily available stimulant worldwide, if I may put it that way. So if you consume up to, say, 400 milligrams of caffeine a day, to put things in perspective, an 8-ounce cup of tea is about 50 to 100 milligrams of caffeine, and a cup of coffee is about 100 to 200 milligrams of caffeine. So anything in moderation is okay. So people in general, use caffeine. It acts as a stimulant, keeps them going. And but if it causes adverse effects, that it is causing you to have trouble falling asleep or staying asleep, then we say at least 8 to 10 hours before bedtime, you should avoid every caffeinated product. And the other thing I would point out is the thought that there's caffeine only in tea and coffee, is not true. You have these energy drinks, you have these soft drinks, all of them have caffeine. So be mindful of that, that there is caffeine in all these products. So if it is affecting your sleep, we recommend not taking any caffeinated products 8 to 10 hours before bedtime.
So the homework actually relies on me. Now I have to make sure that I read all the ingredients, not just coffee and chai. Exactly. That's actually wonderful. That's a myth that I busted today. So thank you for that. So tell me, you touched upon sleep apnea. What is sleep apnea and what are the symptoms? Like how do someone like me or people who are listening to us, how do they know that they have sleep apnea?
So that's a very good question. So I'll point out by saying that everyone who snores does not have sleep apnea, but everyone who has sleep apnea snores. So the way it works is you breathe through your nose or through your mouth, and as the air goes towards the back of your throat, at night when you're sleeping, more so when you're on your back than on your sides, there's a tendency for that airway to collapse. And that is what we measure by means of a sleep study. And depending upon the number of obstructions, we come up with a number, whether one has mild, moderate, or severe obstructive sleep apnea. And this is based on the number of obstructions, complete or partial, every hour of sleep. And then this is associated with high blood pressure, stroke, heart attack, high blood sugars, irregular heartbeat, and blood clots. So you can imagine any patient who walks into a primary care clinic who does not have one of these 6 diagnoses, but we never think about it. So we should always ask a simple question. So like you asked, why should we be suspicious of it? There's a simple screening tool that you can use. It's called STOP, S-T-O-P. S, do you snore? T, do you feel tired during the daytime? O, has anyone observed at night that you stop breathing? And P stands for high blood pressure. So if you have 2 out of 4, then you should talk to your primary care physician and get, tested for sleep apnea. I mentioned it is not just the snoring which is of nuisance value, but the ramifications and associations it has with all these conditions that I mentioned. And if you have sleep apnea, we have a fix for it. And obviously, people have used the machine called the CPAP machine, which involves you wearing a mask, and the different kinds. Some that slip in your nose, some cover your nose, and they're connected by a hose to a pump with the aim to force air under pressure to keep the airway open. Some people have used oral appliances. There is something called like a ProVent device, which is a one-way valve. You just put it on your nostril. When you breathe in, air moves in. When you breathe out, it prevents air from coming out, creates back pressure to keep the airway open. Some people undergo surgery on the back of the throat. I would recommend against it because it's not effective. I just mention it because you may read in the papers, etc. And last two things to complete the list of treatment. One is like a pacemaker called Inspire, which goes in your chest with one lead going up into your cranial nerve and one to your intercostal muscle. So at night you turn it on, and each time you breathe, it forces your tongue forward to prevent your back from collapsing. And last but not the least, depending upon the anatomy, if you have a lower jaw that goes back a little bit, you can do what is called as a maxillomandibular advancement. It's major surgery where basically you're breaking the bone and moving everything forward. So this is what the obstructive sleep apnea. There's also another different kind. I don't want to confuse, but with obesity, obstructive sleep apnea is the one that is most, commonly seen. And I mentioned its association with so many different medical conditions. And so one other myth people have is, I'm not overweight or obese, so I don't have sleep apnea. So 70% of the people who have sleep apnea are obese. That leaves you with 30% who may have sleep apnea that's obstructive, but maybe normal in weight. So just go with the STOP questionnaire. And if you want to increase the sensitivity, you add the term BANG. BANG stands for body mass index, A stands for age, N stands for neck circumference, and G stands for gender. Just for the common lay person, if you have a neck circumference greater than 17 inches in a male and 15 inches in a female, that is a risk factor for obstructive sleep apnea.
Well, I know what I'm going. As soon as I'm done talking to you, I'm going to be measuring myself to make sure I'm not more than 15. I really, really appreciate it. If you don't mind, for our listeners, can you repeat the STOP, like the STOP for us one more time?
So S stands for snoring. T stands for, do you feel tired during the daytime? O stands for, has anyone observed that you stop breathing at night? And P stands for high blood pressure. So 2 out of 4, that's a good enough screening. But if you want to increase it, you can add the term BANG. B stands for BMI. So if you have a BMI above 30, that's mild obesity, 35 moderate, above 40 moderate, severe obesity, morbid obesity. A stands for age, N stands for neck circumference, and G stands for gender. It's more common in males than in females up to a certain age. And after that, it becomes sort of equal in males and females.
Wonderful, Dr. Anup. Thank you so much for the recap. Well, with that, I will be wrapping up eGlobal Doctor. आप सुन रहे थे Facebook Live पे. eGlobal Doctor is one complete healthcare platform solution for all your medical related issues and questions. And मजे की बात ये, the services are available to you at your fingertips without breaking your bank balance, and कहीं जाने की भी जरूरत नहीं है. With the comfort of your home, you can get the consultation and services you are looking for. They are available to you on LinkedIn, Facebook, Instagram, Pinterest, YouTube, Twitter, या फिर old-fashioned way, which is eGlobalDoctors.com. So before I let you go, Dr. Katyal, any word of wisdom that you would like to share with our listeners?
So I still would say that, when we talk of insomnia, then make sure, there are simple sleep hygiene tips that I mentioned, that you should follow, not rely on medications. And if you are obese, work, towards losing weight. And that would be something I would strongly advise everyone.
Well, thank you so much. There you have it. This is Arjay Kunjan signing off. See you next time. Sayonara. Till we meet again. Stay tuned, stay safe, and keep smiling always. And thank you so much, Doctor. It was a pleasure having you. Namaste.
Thank you so much.